Bismillah ar-Rahman ar-Rahim. Dear colleagues, it is my pleasure and honor to meet you in the third webinar of basic endoscopy learning. And in this webinar, I have the pleasure and honor to share my great professor and mentor, Professor Mazen Naga, the head of endoscopy unit in internal medicine department, Cairo University. And I have the pleasure and honor to have my dear colleague, Dr. Shayma El-Kholi. She will talk us about ESD, when to ask for or when to refer a patient for endoscopic submucosal dissection. I will start with my lecture. It is about 25 minutes. About endoscopic ultrasound, tissue acquisition or tissue samples. And in this lecture, I will try to spotlight on some of the tips and tricks regarding this technique. Actually, EUS-guided tissue acquisition have become integral to the diagnosis and staging of gastrointestinal and non-gastrointestinal malignancy, and actually it is the real advantage over other imaging modalities as CT and MRI, because in most instances, tissue is the issue. Our agenda today is the indications, contraindications, complications, some technical aspects, to do FNA or FNB, and at the end of the lecture, we will have a half an hour of free discussion with me, Professor Mazen Naga, and Dr. Shayma El-Kholi. The classic indication for endoscopic ultrasound FNA is pancreatic lesion. This is the first and the classic indication of tissue sampling. Sampling of the bile duct in case of bile duct strictures, sampling of abnormally thickened gastrointestinal wall, and sampling of subepithelial lesion, and sampling of adrenal gland masses, lymph nodes, retroperitoneal or peritoneal masses, and posterior mediastinal masses. Let us talk about two of the non-classic indications of tissue samplings. And I think this is very important. The first one is GIT pathology, when there is a suspected GI wall growth and the endoscopic biopsy is negative. Not uncommonly, we find this picture during upper endoscopy. Markedly thickened gastric folds in the gastric fundus and the body with nodulations. This picture is highly impressive of a malignant lesion like adenocarcinoma or lymphoma. But endoscopic biopsies with usual forceps, sometimes and frequently in up to 50% of cases, in case of adenocarcinoma or lymphoma, especially lymphoma, but come back to be inconclusive, just inflammatory lesion. Many of these cases were referred for endoscopic ultrasound to have an idea about the wall thickness and regularity. Here, this is the endoscopic ultrasound of this lesion, and this is the normal wall of the GI from the stomach, esophagus, duodenum, or the rectum. The normal wall is about 3.6 millimeters, say 4 millimeters, and consists of very distinct 5 layers, 3 hypoechoic layers with 2 hypoechoic in between. So the most hyperechoic is the mucosa, muscularis mucosa, submucosa, muscularis propria, and serosa. Here in this lesion, we notice that there is marked irregular thickening of the gastric wall, even if it is replaced by a soft tissue mass involving all layers and extending beyond the serosa by pseudopodia, there is complete loss of wall layer structure. So this lesion is highly impressive of a malignant lesion, whether adenocarcinoma or lymphoma, based on endoscopic picture and also on endosonographic picture. But the problem is that conventional biopsies are repeatedly negative. So we can say that the thief is there, but we can't catch him. Then what to do for histopathological diagnosis? Some recommend several endoscopic biopsy from the same point. That is what known as biopsy over biopsy technique. Some recommend doing jumbo biopsy by jumbo forceps. I didn't use it before. Some recommend snaring of a prominent part of the lesion. This is very, very yielding and very effective, but sometimes carries a little risk of bleeding. Then why not to do EUS-guided fine needle aspiration? It is a very simple and very safe maneuver because the echo endoscope lies close to the markedly thickened gastric wall, no intervening vessels, no intervening important structures. So it is very safe to do sampling of that markedly thickened wall. This is the lumen and this is the thickened wall. The normal wall thickness is about 4 millimeter. This is more than 12 or 13 millimeter. We can do it by fine needle aspiration needle, or better in these instances, it is better to do with fine needle biopsy, not fine needle aspiration, to obtain enough material for immunohistochemistry or immune staining, because in these instances or in these patients, we are suspecting adenocarcinoma or lymphoma. So it is very easy to do EUS-FNA. And a nice trick here is when you are in contact with the thickened gastric wall, try to do a little bit downward deflection by the big wheel. Downward deflection will bring the echo endoscope more parallel to the wall, so we can travel for a longer distance inside the wall to obtain enough tissue. So I think this is a very good and very valuable indication of EUS-FNA or tissue sampling. In Cairo University, we did a very nice study on 92 cases with diffuse wall thickening, but with negative endoscopic biopsies. The sensitivity of EUS-guided FNA in that case is 83%. So the EUS-FNA can diagnose 80% of cases of gastric adenocarcinoma, gastric lymphoma, and very few cases of eosinophilic gastroenteritis. And the specificity is 100%. So this is a very nice indication of EUS-FNA, markedly thickened gastric wall with negative usual or conventional endoscopic biopsy. Another important job of EUS-FNA is biliary strictures. When we find a biliary stricture, the first and most important question is, could it be malignant? And the second question, where is the stricture? Is it a proximal one, hilar stricture or near the porta hepatis, or it is a distal CBD stricture near the papilla? Both are totally different. 80% of the proximal strictures are malignant, distal cholangiocarcinoma, and it is usually in the form of diffuse wall thickening of the proximal. The proximal biliary stricture is malignant in about 80% of the case, and the proximal stricture is usually in the form of diffuse wall thickening, not in the form of the mass. So it is difficult to be diagnosed by FNA. The sensitivity here of FNA is only 60%, and the negative predictive value is 50%. So here the modality of choice after doing MRCP and MRI, here the first choice after that is cholangioscope and spyglass. Or during ERCP, we can do bile cytology or brush cytology. This is in contrast to the distal CBD stricture. It is 50 to 60% of these strictures are malignant, distal cholangiocarcinoma, and it is usually in the form of solid masses. So it is more easy to be diagnosed by fine needle aspiration. The EUS sensitivity here is about 90%, and the negative predictive value is about 85%. This is an example of distal CBD stricture. Here the echo endoscope is located in the second part of the duodenum, upper second part of the duodenum, and this is the pancreatic head, and this is the distal part of the common bile duct, and this is the lumen of the CBD. Here we notice there is not only marked thickening of the wall, but also mounting to a mesh formation. Although it is a small mass, but it is a mass. So it is very easy to sample this mass by FNA or FNB. So the distal cholangiocarcinoma are usually in the form of a mass, so it is very easy to be sampled by endoscopic ultrasound FNA, and here EUS is the first modality of choice after, of course, doing CT and MRCP. So it is very easy to do it, and the yield is very high. This is in contrast to the hilar stricture. Here we are in the porta hepatis. This is the liver, and this is the region of the liver hilum or the porta hepatis, and this is the portal vein, and this is the hepatic artery, and here this is the upper or the proximal part of the common bile duct with a stent inside. You notice that there is minimal thickening of the proximal CBD. It may be a malignant stricture, very early cholangiocarcinoma, or it may be an inflammatory stricture like ulcerative, like sclerosing cholangitis or autoimmune cholangitis in IgG4 related disease. A part of IgG4 related disease, autoimmune cholangitis. Of course, it is very difficult to sample this wall because it is away from the echo endoscope. There are many intervening in important structures like the hepatic artery and the portal vein, and also the wall is very minimal. How can I do the to and fro movement inside this minimal wall? So here, the modality of choice is cholangioscopy or spyglass. Here, another trick is to try to sample a nearby lymph node. This is a nearby lymph node in the porta hepatis. Actually, it looks a benign lymph node because it is elongated, flat lymph node, and not so echopoor with preservation of the hyperechoic hilum. But if I sample this lymph node, and this lymph node proved benign, then it is mostly a benign lesion. But if this lymph node is malignant, then sure, it is a Klatskin tumor or proximal cholangiocarcinoma. This is the portal vein, and this is the hepatic artery, and this is a porta hepatis lymph node, and this is a proximal common bile duct with minimally thickened wall. These are two examples of a hilar stricture with nearby lymph node. Here, this is a previous case, the lymph node looks benign, but here this lymph node looks very malignant because it is rounded rather than elongated, anechoic or more black with loss of hyperechoic hilum. Here we can do EUS-FNA of the porta hepatis lymph node in the two cases. This is very near to the echo endoscope, no intervening structure. This case proved to have a benign lymph node, but this case proved to have a malignant porta hepatis lymph node. So these patients sure have a malignant hilar stricture, Klatskin tumor, proximal cholangiocarcinoma. So sampling of a nearby lymph node may give an indirect evidence of malignancy. Okay, then we come to the contraindications. There are absolute contraindications and relative contraindications. The absolute contraindications are inaccessible lesion or large duct and vessels intervening between the echo endoscope and the target. And if the primary lesion is interposing distal lesion, as we'll see later, or of course fine needle aspiration will not alter the management. The relative contraindication is anticoagulation or antiplatelet. You can stop it for 5 days or 7 days and replace by fractionated heparin or low molecular weight heparin, and discontinue it 12 hours before the maneuver. But after we do so, it is better to use 22G needle, thin needle with minimal passes, 1 to 2 passes. Some tricks in EUS FNA. Try to avoid traversing a vein for fear of bleeding, or traversing an obstructed duct like the common bile duct. If there is no stent, I fear to pass through the common bile duct because this may induce infection and cholangitis. But if the patient is stented, this is a safeguard mechanism against cholangitis. And I try to avoid passing through the pancreatic duct because this may induce abdominal pain and pancreatitis. And never traverse a major artery. You can, in some instances, when you are obliged to, you can transverse a vein, but the artery, the pressure is very high. And major arteries may be atherosclerosed, and this may induce a break aortic dissection, for example. This is an example. While I am in chest in the mediastinum, this is the aorta, and these are malignant looking lymph nodes. Never pass through the aorta to sample these lymph nodes. Some do it, but it carries a high risk of bleeding and high risk of aortic dissection, and there are recorded cases of aortic dissection after traversing the aorta to reach a target behind. And this is a nice example of a malignant looking pancreatic head mass, and this vessel interposed between the duodenal wall and the pancreatic mass is the gastroduodenal artery. Here are the mesenteric vessels, mesenteric vein and sphenomesenteric vein and sphenomesenteric artery. It is away from the path of the needle, but the artery which is interposed between the echo endoscope and the mass is usually the gastroduodenal artery. Here, if I pass by the needle like that, it may hit the gastroduodenal artery and induce bleeding. So it is better to avoid passing through this vessel. I can manipulate the echo endoscope to find a window. Here, this is the gastroduodenal artery, as evidenced by the pulsed wave Doppler. And here, this is the needle. I try to locate the needle away from this vessel. Take your time. Don't be in a hurry. But the most important is to be safe. Here, this is the needle. Now I pass behind the artery. You see, this is the gastroduodenal artery, and this is the path of the needle. You will find some window to avoid traversing the gastroduodenal artery. The another trick is don't sample a distant lesion behind a primary lesion. As in this case of markedly thickened wall of the gastroduodenal junction. This is the wall of the gastroduodenal junction. Looks like adenocarcinoma mostly. And this is a lymph node. This lymph node may be benign, may be malignant. Don't sample this lymph node because you should traverse through the malignant looking wall. Because if this lymph node is benign, and while you are passing through a malignant lesion, you can translocate some of the malignant cells to the lymph node, so increasing the staging of these patients from N0 to N1. Try to find a window to sample this lymph node without passing through the primary lesion. Actually, in this lesion, I can't, because the lesion is so long, so extensive, so there is no window to sample this lymph node. So I sampled only the wall, and this is enough for diagnosis, and I can sample this lymph node because I shouldn't traverse a primary lesion to reach a distant lymph node. This is a very nice case which I'd like to share with you. A very difficult case, one of the difficult cases I had ever seen. This female, I think it is 45 years old female, complaining of epigastric pains, and CT revealed this small mass at the neck of the pancreas at the level of the venous confluence of portal, splenic, and superior mesenteric vein. So this is a mass, a very small mass. It is about 9 millimeter. There are 4 difficulties in this mass. Actually, this lady under EUS FNA before, and the sample is inconclusive, so it was referred for another trial of FNA, because it is very important to know the nature of this mass. Actually, there are 4 difficulties in this lesion. The first one, it is small, is about 9 millimeter, but this is not a matter. We can sample a very small lesion. The second, it is away, it is deeply seated in the pancreas, it is away from the endoscope, and this is not so difficult because we can extend the needle to reach any site we want. But the real difficulty is that this lesion was very hard, and it is located in a normal healthy pancreas which is soft. So when the needle approaches the upper aspect of the lesion, it is pushing the needle or shaking the needle and not moving through it. What to do by then? We can do the very nice technique of door knocking technique. What is a door knocking technique? The door knocking technique is that when you reach the upper aspect of the mass, then you can do shaking movement as we will see together. Okay? Have a look with me. Here the needle is at the upper aspect of the lesion. I tried to push it, but the needle is pushing the mass and it's shaking the mass and not moving through it because the mass is very firm and located in the soft normal pancreas. Then what to do? Try to do a door knocking technique. You adjust the stopper 1 centimeter below the handle when you approach the upper aspect of the needle. Then fix the stopper 1 centimeter below, and then start to do what is known as staccato movements or sudden repeated pushes. You know that voice like knocking on a door. We tried several times, and as you see with me here, after applying door knocking technique, the needle is now starts to move inside the needle, to move inside the mass, and not shaking or moving the mass as a whole. Concentrate in that video. You notice now that we are starts to move inside the mass. So it is very difficult mass because it is small, so the range of movement inside is very limited. It is 9 millimeter. It is very firm and located in a soft normal pancreas. Now, very nice. We are now starts to move inside the mass. And fortunately enough, the cytopathological diagnosis was low-grade duct adenocarcinoma, and the patient underwent partial pancreatectomy. Now come to the complication. The complication is perforation, very rare, about 1 every 1,000 patients. And usually the perforation occurs between the first and second part of the duodenum. As you all know, when you go by the echo endoscope to the second part of the duodenum, you do right and up, like the movement of the fundus. Right by the right knob and up by the big wheel. When we will try to withdraw, to push the echo endoscope inside the second part, perforation may occur. So you should be very careful. And in small number of patients, and with marked inclination between the first and second part of the duodenum, sometimes it is very difficult to pass to the second part. In a little percent of patients, 1 or 2 or 3 patients every 100 patients, then you can screen from the bulb of the duodenum and from the stomach, as we mentioned in the previous webinars of examination of the pancreas from the stomach and the bulb of the duodenum. You can do it from station 3 and 4. The second complication is infection, especially in cysts, whether pancreatic or somewhere else. And when you do sampling of a rectal lesion due to the presence of the bacteria inside the rectum, so we should go prophylactic. We should give prophylactic antibiotics before sampling. One of the complications is hemorrhage inside the lesion, especially gastrointestinal stromal cell tumors, because it is a rather vascular tumor in contrast to leiomyoma, which is usually hypovascular, or neuroendocrine tumor. So try to sample the periphery of the lesion, and you should apply Doppler before starting sampling to choose an area with no marked vascularity. So you should sample an area with no significant vasculature inside. And of course, you should be sure that the platelet and INR and PTT are normal. One of the complications of EUS-FNA or FNB especially is pancreatitis. If you pass a long distance in a normal pancreas to reach a lesion, especially small lesions, if the lesion is small, 1 centimeter, then you should travel for some distance inside the normal pancreas, but you should are obliged to. So here, the advice is try to pass as short as you can through the normal pancreatic tissue to avoid pancreatitis. And seeding may occur, translocation of malignant vessels, higher in cystic lesion. In cystic lesion, try to do a single puncture and to do complete evacuation of the cyst to decrease the pressure inside, to prevent oozing of some fluid in the nearby tissue, to minimize seeding. This is an example of gastrointestinal stromal cell tumor. Here, with application of Doppler, there are marked vascularity or significant vascularity. This is the FNA, and this is bleeding inside. So try to sample the periphery of the lesion, not in the center of the lesion, and try to choose an area with minimal vasculature. This is one of my cases. This was a left suprarenal cyst. And after FNA, I found this fresh bleeding, hyperechoic fresh bleeding. And here there is a vessel inside. This is the bleeding vessel, very nicely seen. This is a bleeding vessel in a cyst. I observed the patient while the echo endoscope inside the patient. I waited for a few minutes. The bleeding increased, but the bleeding vessel stopped. Thanks God for that. The bleeding increased, but the bleeding vessels stopped. Why? Because with bleeding, with continued bleeding, the pressure inside the cyst is increasing. So the high pressure inside the cyst will compress the bleeding point. So don't be afraid. Most of the bleeding inside a cyst will stop spontaneously. Just observation, no need for further intervention. because the continued bleeding inside the cyst increases the pressure inside and compresses the bleeding point. This is a video from one of my colleagues. I had the permission to put it here, and this is FNA sampling of a pancreatic cyst, and here we notice that there is a significant bleeding, and this bleeding, of course, it is an arterial bleeding because it comes in jets. Don't afraid, don't be panic. This bleeding will stop in near 100% of cases, because as I told you before, the pressure increased, and the increased pressure will compress the bleeding vessel, whether venous or arterial. Okay, now coming to the last part of the lecture, what is the different techniques of EUS tissue sampling? There are many points to be issued or to be raised. The first point, do you use stylet with or without the stylet? Most of the articles, most of the endosonographists show no difference if you use the stylet or not. But I prefer to use the stylet to prevent contamination of the sample by the gastrointestinal wall. Sometimes, especially in GIST tumors, when you pass from the wall to the tumor without a stylet, you can contaminate the sample by the muscle layer of the wall, and so the myocytes, the cytopathologist confused whether this myocytes is from wall contamination, from the muscularis propria of the wall, or from the GIST itself. Experienced cytopathologists can differentiate, and the immunohistochemistry can differentiate. The second point is to do a slow pull, low pressure or capillary technique, or high pressure technique by the syringe. Most of the literature says no difference, but what I am doing is to apply Doppler first before sampling. If the lesion is hypervascular, as in some GIST tumor and neuroendocrine tumor, I use the slow pull or low pressure technique to avoid bloody samples. And I choose the first pass. If the material is enough, then I do the second and the third pass by the same technique. But if the material is too little, then the second pass I apply high pressure. And the opposite. If I apply Doppler first and the lesion is hypovascular or avascular, like in cases of pancreatic adenocarcinoma and leiomyoma, I start with high pressure. The first pass with high pressure. If the sample is not bloody, then I continue the second and third part with high pressure. But if the sample is bloody, then the second pass I use the low pressure or the slow pull pressure to obtain a non-bloody sample. How many passes? At least 3 passes. If you don't have rapid on-site evaluation, then you should do at least 3 passes. Fanning technique is very important because it raises the accuracy or the sensitivity of tissue sampling from 60% to 85%. We all know the fanning technique is to try to obtain biopsy from the central part of the lesion and also the peripheral parts of the lesion. You can change the course of the needle by the elevator or the lever, or by pushing the echo endoscope slightly inside the patient for a few centimeters. This will change the direction of the needle from the center to the periphery or the opposite. So the fanning technique is very beneficial. MOSE, macroscopic on-site evaluation. Macroscopic on-site evaluation is to observe grossly the sample you obtained. If there are white or grayish parts, then it is very nice. It is a tissue. But if all the sample is reddish, then it may be a blood contamination. So when you find whitish material or grayish material, this is very nice and the sample will be enough. What about ROSE, rapid on-site evaluation? Yes, this is very important and highly reliable with excellent agreement with final cytopathologic diagnosis. And actually, this is the best thing you do is to have a cytopathologist beside you. But unfortunately, in most instances, the cytopathologist is too busy. So in my experience, in more than 80% of the occasions, I don't have ROSE. ROSE is available in only 10 or 20%. And I need ROSE if the first pass, or if not the first pass, if the previous biopsy is negative and the patient came for another trial of EUS-FNA, then I do every effort to provide a cytopathologist beside me for ROSE. So ROSE is very, very, very helpful if available. I think the most important factor in determining the yield of EUS tissue sampling is local or central cytopathologist. Experienced or experienced cytopathologist. This is, I think, the most important factor, and it is the most decisive factors. In many instances, I send the patient to go to someone, and the biopsy is inadequate, bloody, hemorrhagic, and when I repeat the cytopathology with an experienced one, that is called rereading or second opinion, it proved to be malignant and it proved to be cellular. So I think cytopathologists all over the world is a special art. So you should always refer your samples to an experienced cytopathologist. So the most important factors in increase the yield of EUS-FNA, fanning technique is useful, MOSE is useful, ROSE is very important, local or central cytopathologist is decisive. Now come to the last slide, or last two slides of my lecture, and the famous question and everyday debate whether to use FNA or FNB. Many years ago, there was a needle which is called the true cut needle. It is a 19-gauge needle with a spring-loaded biopsy. But it is not suitable for every site, especially in the duodenum, because it is 19G needle. And in the duodenal, the position of the echo endoscope is a long position, and the external part, the most distal part, the distal segment of the echo endoscope is usually bended. So it is difficult to manipulate a thick needle, 19G needle, with a bended external segment of the echo endoscope in the duodenum. And there is some complications, a little bit more incidence of bleeding. Now, in common use are the fine needle biopsy, are ProCore, Acquire, and Shock Core. These are newer types of needle available to obtain a core histologic sample in order to improve diagnostic accuracy and important for immunochemical staining. Then what to use, FNA or FNB? In most of my patients, I use FNA needle because it is very manipulative, very easy to use, very easy to move with the lever, very malleable, very deformable. But in cases when I suggest that I need immune staining, I should do fine needle biopsy. Especially in cases of lymphoma, you should do CD markers, and in GIST tumor, you should do 117 and DUOD-1, and in autoimmune pancreatitis, you should stain for IgG4 receptor on the plasma lymphocytic cells. So the answer of the question, FNA or FNB, the first according to your preference. If you are used to do FNB, then use FNB. If you are used to use FNA, then use FNA. But if you are suspecting that the patient may need immunostaining, like in lymphoma, GIST, or autoimmune pancreatitis, you should do FNB by FNB needles. This is the types of FNB needles. This is a Procore, 2 types. Here the bevel is near the distal end, and here the bevel is away from the distal end. The size is 22, 25, 19 in all needles, but here another needle is 20, which is the recoil needle, which I think it is very good. When I decided to do FNB, I use 20G Procore needle. Now come to the take-home messages. EUS tissue sampling may be very valuable in endoscopic biopsy negative GI wall malignant looking lesions. Sampling of portahepatis lymphadenopathy may give an indirect evidence of hilar clad skin tumors. Fanning technique, rapid on-site evaluation, and experienced cytopathologists are the most useful factors in increasing the yield of tissue sampling. You may do FNA or FNB according to your preference, but FNB should be done if immune staining will be needed to reach the final diagnosis. And thank you very much for your interest in endoscopic ultrasound, and thank you very much for your attention.